Basically, I try to organize this in three parts. Before the surge of patients there, during the surge, and after the surge. You probably already passed the before stage, and most of you are already in the during the surge stage. Sorry, it's a little late, but hopefully you have done all this already. So what we did here in the US, especially for the company that I work for, we have about 100 hospitals in the United States, about 1,000 clinical engineering professionals in all the major cities and also in many small cities in the United States. Okay, so we prepared for the surge by assisting in expanding the ICUs and emergency departments, by installing new equipment, recovering old equipment, moving equipment from ambulatories to ICUs. You probably did the same thing. We performed the scheduled maintenance before due dates that are less than 60 days ahead when we could, and we check and replenish parts and maintenance kits. But the most important part for us was to plan for staffing. We knew that we could not risk to have everybody together and get everybody sick at the same time. So we decided to map our competency. In other words, who is capable of fixing ventilator, who is capable of fixing imaging equipment, who is competent at fixing infusion pumps. And we divided that, and I'll show the list of equipment in a minute. And then we divided our technicians into two teams that can cover all the major critical equipment. And then we schedule them to come into the different shifts, one in the early morning, the other late afternoon, or to different days, one coming Monday, Wednesday, Friday, the other coming Tuesday, Thursday, and Saturday. Okay, because we want to make sure that we have at least one team available in case one team gets contaminated. We still segregated the workplace 2 meters of distance. We segregated the two test equipment if possible. Okay, we allowed some older immune compromised persons to work from home, cross-train people on critical equipment, and kept online a contact list with name, telephone number, backups, etc. So we can provide support even remotely if necessary. And communication. We contacted manufacturer, distributor, third-party service company to see whether they are prepared. They can really come to the hospital to help us, or they have a problem, then we need to find other alternatives. Also, we contacted neighboring hospitals to see whether they are willing to collaborate and share resources. Some hospitals even traded equipment, and some even provided technicians to help others, etc. So this is very, very important. And also, we were extremely careful about the so-called innovative solutions. You know, there were many, many requests for decontamination of face masks, using a single ventilator for multiple patients, using anesthesia equipment as a ventilator, using CPAP as an invasive ventilator. All these things came up, and we tried very hard to provide accurate, reliable information instead of just saying, oh, just go ahead. Oh, we can do this. No problem. We'll try this. We'll try that. Remember, we are not clinicians. However, we have the same Hippocratic oath and duty of first do no harm to our patients. We are not using patients as guinea pigs here. Of course, in some dire circumstances, even the physicians, surgeons have done very, let's say, tentative things, but we try very hard not to do things that we don't have full assurance that it's safe, and much less if it's not effective. Okay. Now, fortunately, you have more information about these things, so you should be able to get reliable information for your clinicians there. The list of equipment that we prepared are here. You probably recognize most of them. I don't think I need to read every single one. You probably already did that. There are some that we believe are important, but they are not critical, or but we still prepare them. And also there are some that we believe are optional, or some became necessary, like ECMO, the extracorporeal circulation machines, or these membrane oxygenator machines. These are really very, very rarely used, but in a few occasions they were used. Uh, Likewise, hemofiltration, hemodialysis, etc. And facility management is something that you need to talk to your colleagues, because very often the oxygen supply is not enough to power so many ventilators, so power issues, filtration, air conditioning, etc. So you need to coordinate well with your colleagues, because it's not just equipment issue. You need to make sure that the utilities can support what the patients need. Okay? So during the pandemic, this is what we're doing now. We are first protect your staff. We fight for our staff. We end up buying our own face masks to provide to our own workers, because sometimes hospitals don't have enough. So we went out and spent more money to buy this. Although in theory the hospital should provide that. We limit access to the shop and trips around. We decontaminate all the incoming equipment. We wear full protection when we go into the emergency department, ICUs. And also we make sure our people decontaminate their workplace to test equipment before and after the end of every work shift. Again, because we don't want to lose our staff, okay? Only in one hospital we had a very bad situation, because it's a very small hospital. We had only 4 people there, and we had to isolate them because they developed initially some symptoms that turned out they were not COVID actually infected, but became a serious problem. Of course, wash hands, sanitizer, change clothing if possible, and adjust staffing whenever needed. And this has worked well here. Equipment service, focus on repairs of critical equipment. We postponed a lot of maintenance that is scheduled, and we convinced finally the American government to allow us to do that. Initially, they were reluctant, and we could show them there is no really reason for us to waste time doing scheduled maintenance on a lot of diagnostic equipment that is not being used. Okay. And also we seek and offer assistance to neighboring hospitals, as I mentioned before, and monitor resources that make sure that they are available. Okay. And uh, above all, remain calm and rational. Don't panic. If you panic, you make mistakes. Okay. And keep your in touch with your staff. Make sure that mental well-being is very important. A lot of people got exhausted mentally more than physically. So this is something very critical. You need to give them rest. You need to give them some time to relax and recover. Okay. After COVID, we are not there yet, but hopefully we will be there soon in some places. And we are going to try to use the antibody tests. Otherwise, we have to wait 14 days after the last confirmed patients have been discharged to know that the pandemic has left that particular facility. At that time, then we will be catching up with the postponed scheduled maintenance. And also we want to do a post-mortem. This is what the doctors do when they lose a patient. They discuss the case, what worked well, what did not work well, what surprises you found, what needs to be improved, and who from outside you can count on the next time, and who you cannot, because this is an important lesson that you need to learn and use for future situations. Sorry for being not exactly pessimistic, but realistic. This will happen again. We have had pandemics in the human history for many, many centuries, and it's not going to go away. It may not happen in 10 years, 15 years, 30 years, even in your lifetime again, but it will happen again. Okay, so try to be prepared for it and try to teach the younger generations to be prepared for it, because this is part of the natural mother nature biology. Okay, all right, I think I'm done here.
Thank you very much for this wonderful presentation, Professor. We have some couple of questions. The first one is that at the beginning of your presentation, you mentioned that it's very important to know why, the why of the medical equipment failure, not what failed. According to your experience, what is the percentage of the cases you truly know the case of the failure?
Can you repeat that? I did not follow completely.
Okay, at the beginning of your presentation, you mentioned it is important to know the why of the medical equipment failure, not what failed. According to your experience, what is the percentage of the cases you truly know what is the case of the failure?
Okay, fair question, good question. It is not always possible to know the cause of the failure. So very often I was asked by our technicians who were asked to assign the failure codes with the question, what if I don't know or I made a mistake and guessed wrong the cause? My answer was very simple. There is in the statistics a concept, a doctrine called the law of large numbers, meaning it's like you toss your dice. If you go to a casino or you play cards with your friends, you toss a dice. The dice has 6 numbers, right? And of course, if the dice is completely fair, equally arranged for all 6 faces to show up, it's very difficult for you to find out what's the number you should guess. But if it's biased, one side is heavier than the other, for example, then you will systematically show a bias, and you will not find this out in 1 time, 2 times, 3 times, even 10 times. But if you toss enough the dice or a coin, you will find out that whether this is a biased or not, dice or coin. And then with this statistics, you will be able to say, okay, I see that it will fall on number 5 more often than others. So my guess is going to be number 5 because I'm betting on the law of large numbers, on the average. Okay, and this is the same thing here. It doesn't matter if you make a mistake, but if you consistently try your best, at the end of the day, your mistake here and there will be washed out by the correct judgments made by others and including yourself maybe later. So don't worry about it. Just go ahead and do it. You will make mistakes. I made many, many mistakes, but on average, if you try to improve and learn from yourself and from others, you will make the right decisions. And that's the reason I believe that it's possible to determine the cause, the why, and then the why tells you what you need to do. If this electronic board failed because it's a random electronic failure, fine. But if it's related to a thunderstorm that came to the building, the the thunder the reached the electrical outlet and overcharged, burned the machine, then okay, that's not a random electronic failure. This is because of a use situation, and therefore it's a different cause. So you need to find out why your equipment failed. Hopefully I answered the question.
Thank you, Professor. We have another question from Manuel Bornas. He would like to know if the field corrective action is into corrective maintenance or can be used to consider a redesign of equipment?
No, when I mentioned about corrective action and preventive action, it's for correcting the strategy of maintenance. For example, if I decided to perform maintenance instead of annually as suggested by the manufacturer, I decided to go and perform maintenance every 3 years only. And then I find out from the outcomes that there are more failures than I anticipated. Then I said, "Oh, that's not good." When I was performing annual inspections, I found much fewer problems, failures than when I did every 3 years. So, okay, my corrective action is to shorten this to 2 years or maybe 18 months. I still want to stretch the time, but I will not stretch that far. And the preventive action is that, okay, I did this for this particular brand and model of infusion pump, but how about other brands of model infusion pumps that I have that I did not have enough statistics to analyze? Let me take a look whether these other brands and models use similar technology in building the pump. If the technology is similar, I may want to also apply the change to that strategy, those pumps, and not just to the first group. So I'm doing this as a preventive action because I don't want to make a corrective action later when I have too many problems. Okay?
Okay, Professor, thank you. We have another one that is mentioned that the implementation of the Six Sigma procedure could be improved by the implementation of a lean methodology that is based on build, measure, and learn.
The evidence-based maintenance is actually a lean method, actually, to be honest. Okay, I just did not want to bring a lot of concepts here uh, because I think that is likely to confuse a lot of people. But by reducing the amount of unnecessary scheduled maintenance, you are naturally reducing your expense. And that's part of the lean process. Do not waste. Okay, you are wasting PM kits if you are replacing things unnecessary. You are wasting time of the staff if the inspections are not necessary. So these are lean concepts. But I much rather use the term evidence-based because that is, as I mentioned before, easier for us to explain to our clinical colleagues. Since we work in a healthcare industry, for them, lean is something a little bit different coming from industrial sites. So a lot of people say, it's difficult to understand. I don't want to understand that it's complicated, etc. But when you say, oh no, this is nothing different from your evidence-based medicine, is something that they are very quickly to understand and accept.
Thank you, Professor. We have another question from Luis Fernandez.
Hey, Binseng, I just wanted to get your opinion on a lot of initiatives that right now for COVID purposes are constructing or building technology. You know, there's a lot of fuss going on social media and news feeds about the prototypes being developed, but I strongly believe that there is a lot of risk to be faced in the near future because of low safety considerations towards patients. So I just wanted to get your thoughts on this and maybe some tips so that we could help out as clinical engineering specialists and enthusiasts, because it might seem that people get sort of offended when you ask them about electrical safety or patient simulation or even ventilation parameter measurements. So I just wanted to get your opinion on this topic.
Very good point, Luis. Yes, I personally, I admire the people who want to be innovative and try to do the right things, but I think a lot of them unfortunately don't have the experience in trying to create a piece of medical equipment from scratch and then transfer that to production and then ultimately to uh, 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 a healthcare environment. It is a very complicated process, first of all. Second, we need to be honest and realistic because we don't truly understand how human beings work. We can fix a piece of medical equipment fairly well, even sometimes without instructions from the manufacturer. This is because machines are built by human beings. Human beings think in somewhat similar manner, use somewhat similar approach, etc. Now, whoever designed, created human beings did not give us the blueprint, instructions, or anything. We are struggling to understand how normal physiology works, and much less how pathological condition works. For example, a lot of people say, well, I can use a ventilator to provide oxygen air to two patients at the same time by using a T tube, a T connection or Y connection. Yes, you can. However, you have to remember the two patients may not be identical in physical size, in condition, etc. And on top of that, one of them may all of a sudden deteriorate quickly, and then what's going to happen? We are not talking about rubber balloons here. We are talking about lungs that may have a significant challenge in tolerating high pressure or excessive volume of air. And so it is not that simple. The smart machines, ventilators that have been designed, try to adjust for these changing patient conditions. But if you have two patients in parallel here, okay, this is not in series, this is in parallel, right? So in parallel, that means that they both receive the same quantity if the this is like a electric circuit. If the two resistors are the same, yeah, you applied a certain voltage, the two gets the same current. However, if one resistance changes, then the higher resistance one will get less, and the other one will consequently get more current, and then can become in trouble. Because we are not talking about fixed voltage, we are talking about fixed current that is being issued here, okay? So that is something a lot of people unfortunately forget to understand. And also, what works in a bench, in a laboratory, does not mean that it is something that is usable or reproducible in a manufacturing site. So a lot of people forget that, but one simple example is why infusion pumps are having so much recalls worldwide, not just the United States. If you look back 10 years, infusion pumps by far are the ones that receive the most recalls in the entire universe of medical devices. And they are called smart infusion pumps. But they had lots of recalls. Why? Because they were designed by engineers who very often don't understand fully how the clinicians think, how the clinicians use things. And what is intuitive to engineer does not mean is necessarily intuitive to the nurse or the doctor. And that is why we have all these recalls, and also a lot of unpredictable circumstances were not thought about and therefore became a problem that needed a recall. So you're absolutely right. I personally would much favor enhancing the production of technologies that we already have proven that it works than inventing something new, with some obviously exceptions. For example, to make a good face mask or a face shield, these are simple technologies. I totally agree. You can use different material, different technology, and you can make things a whole lot faster, easier, cheaper, etc., etc. Because these are not really medical devices. These are not complicated medical equipment. Okay, but to design ventilators and think that they are going to work when you just test it on a bench and then move into hospital, I think that is a little too naive and potentially unsafe.
I agree. This is a matter of, it's not a matter of willingness or skills, but a matter of focus. Thank you.
Thank you,
My
Professor.
pleasure.
We have another question from Fred Hauser that says, please comment on maintenance functions that you think can be improved by designing device to be more self-aware by building in automatic self-monitoring, alerting, self-healing, managing software, firmware updates, tracking maintenance history, failure and resolution codes, etc. With multi-core chips, devices can do a Internet of Things, I think.
That's fine, Mary. I understood. I saw his
Okay.
question on the chat. Thank you, Fred, for the question. You reminded me that I forgot to talk about the self test that is extremely important. And this is part of the reason that today a lot of inspections are not really very useful anymore. It's quite possible to put most of these equipment into the so-called run to failure or corrective maintenance strategy only. And the example is very simple. Most of you probably not only know how to drive, but also own a car. And you know that the car has a panel. The panel show you many pieces of important information in form of lights, the dials, etc. And your car, most of you probably know that, has probably a couple of dozen of microprocessors there that can tell you whether your tire is underinflated or your brake is not working, etc. And so why would you bother to inspect your car for the so-called safety every year, like many states in the United States are still doing that? It's really not very useful. It's the same concept here for inspecting medical equipment. It is good and safe the moment it was inspected, but no one can guarantee 5 minutes, 5 hours, 5 days, 5 weeks after your inspection, it's working still the same way. Okay, so the self-test is extremely critical, and the alarms there are extremely critical. And by the way, the manufacturers build in those alarms, those error codes, etc., not really only for the users, but also for self-protection here in the United States, because those error codes can save them from lawsuits here in the United States, because they can show very clearly that, hey, the piece of equipment, the infusion pump alarmed, telling you that it's not working properly, and you did not come and save the patient. You ignore the alarm, or you silence the alarm, and you left the patient there to fend for himself or herself. So it is extremely important to make sure that you train the clinicians to watch what is shown there, because it's like the dashboard on your car.
Thank you.
Thank you, Professor. Anyone that's any question, any further question for the Professor Binseng Wang? We have another one. Luis, can you please help me translating this one, because I don't get it?
Sure.
I sent a message.
Sure. Binseng, this question addresses the following. why is it considered a COVID critical equipment, BPAPs and CPAPs, if it allows patient fluids on the environment to increase and consequently increase the risk of cross-contamination?
Yeah, as you know, ventilator is an invasive method. Okay, you have to intubate the patient. You put a cannula in the trach. Okay, and it is a really last resort in terms of saving a patient who has poor oxygenation. And BiPAP is non-invasive, and it can still push a significant amount of air, oxygen into the patient, and in many cases can make the use of invasive ventilator unnecessary, and so it is a good intermediate solution. And if the patient can be saved from ventilation, it actually is a good solution. Now, the CPAP is not as powerful as BiPAP, but it just provides you with a positive pressure, and but it's still a method of providing a higher pressure and more oxygen to the patient, and therefore it is something useful for patients who are not in such a severe deficiency in terms of ventilation. Now, you are talking about the droplets fluids that come out of patient. Yes, indeed, those are risky situations. However, at this point, the patient is already in a isolation unit. In ICU, all the ICUs for COVID are considered isolation areas. The air conditioning, everything has to be HEPA filtered, etc. And the clinicians are using full protection, mask, shield on the face, gowns, head cover, shoe cover, everything. So they are not obviously perfectly protected, but adequately protected in most cases. The intubation actually is the riskiest situation, because now you are inserting a tube, you're cutting the trach, inserting a tube, you're getting very close to the patient, and you can get sprayed literally on your face. That's why you need a face shield. So at this situation, BiPAP and CPAP are alternatives, not necessarily ideal depending on the condition of the patient, but it's an alternative.
Thank you, Professor. Any further questions? Okay, I think we don't have further questions. Professor Binseng Wang, thank you very much for this presentation. It was wonderful, very clear, and it helped us to be more clear with some concepts very important for clinical engineers. Thank you very much.
Thank you everyone for your attention. I know this has been a very tiring and late presentation for everyone. So really like to thank you for your patience. I went through a lot of things very quickly, so hopefully it was understandable. Please don't hesitate to contact me if you have questions, and also would definitely very much like to receive feedback. If you try to use this process, let me know, and any challenges or successes you have. I will be delighted to know about it. Thank you. Have a very nice and safe rest of the evening, and the rest of the week as well. Thank you.
Thank you,
Muchas
Professor.
gracias.
Gracias a todos por participar. Síganos en redes para que podamos compartirles la presentación y la grabación. Muchas gracias. Nos vemos. Buenas noches.
Thank you. Thank you.
Thank you. Thank you.
Thank you. Good night.
Thank you very much.
Thank you. Good night.
Obrigado.